I saw the ways that families and futures were derailed. I saw the ways that people's identities were, obliterated in some cases, changed
Yeah.
completely. And I really couldn't unsee it. And it became obvious that this was a problem in my mind, medical trauma
Mm.
hiding in plain sight.
Welcome to the Medical Trauma Support Podcast, where we come together to bring more humanity into healthcare. I'm your host, Sarah Stasica. Hello, everyone, and welcome back to the Medical Trauma Support Podcast. I am so excited today to have Dr. Jim Jackson with us. Thank you for being here, Jim.
You're very welcome. You're so welcome.
Jim is a neuropsychologist and he works at Vanderbilt and has done a lot of work in the PICS space, a post-intensive care syndrome space, long COVID space, and has written, I know of 2 of your books, but you maybe have written more for those.
Two
Okay.
books.
Okay. So one of them I have here because this is one that's already been published on clearing the fog on long COVID. And he has another one that I have pre-ordered, but it is not here yet. And I'm really excited to read it. And that one's about medical trauma. But I thought, Jim, you could tell us a little bit more about you and what you're doing now.
Yeah, thanks. I'm happy to. And I'm really delighted to be with you. And I want to affirm you. This podcast is important, so important. And the
Mhm.
topics that you're engaging are so important. So thank you. I was a little bit of a late bloomer academically. No one thought that I would write one book, much less two, unless it would have been a coloring book or something like that. No one thought that I'd be writing books or really doing much in the academic arena. I don't think I wasn't a hugely motivated student, and
Mhm.
I did decide at some point in college that I was interested in psychology. I wanted to help people. And
Mhm.
I got into a graduate school program by the skin of my teeth, a master's program. And I met my wife, a woman who is now my wife. And she had a different approach to studying and a different approach to life.
Mhm.
And I embraced that more focused path. And things started to change. I worked at a small hospital in Michigan, got a taste of working with patients with trauma, and then went to California and got a doctorate in psychology and came to Vanderbilt as a psychology resident. That was in 2000. And in those days, a fellow who's become quite famous in the critical care world, Wes Ely, who you might know, famous critical care physician, he was assembling a team of people to study outcomes after intensive care.
Mhm.
And I was a live body. I just happened to be, I happened to be in the area, in the vicinity, if you will. I was a live body. And he met me. He needed a
Mhm.
psychologist, and I needed a job. And it really was that simple. And we shook hands, and we had a baby on the way. I, I thought that the job might really be a placeholder for something
Mhm.
else. I didn't know necessarily that medical trauma would be a topic that would capture me in the way that
Mhm.
it did. And I think what happened as I started working with ICU survivors, primarily in those days, I think what happened was I saw some things that I couldn't unsee, right?
Mhm.
I saw the impact, the adverse impact of being on a ventilator, of being critically ill, of developing illnesses that were life threatening so suddenly without any preparation, right? I
Yeah.
saw the ways that families and futures were derailed. I saw the ways that people's identities were, obliterated in some cases, changed
Yeah.
completely. And I really couldn't unsee it. And it became obvious that this was a problem in my mind, medical trauma
Mm.
hiding in plain sight.
Yeah.
And I pulled the string, if you will, the medical trauma string, and things started to really unravel. I started to realize that this was a problem not only in ICU survivors, it was a problem in patients with chronic illness. It was a
Yeah.
problem in family members. It was a problem hiding behind almost every corner. Not everyone who has a difficult medical experience, to be sure, has medical trauma, but
Mhm.
millions of people around the world do. Millions of people do. And
Yes.
once I started to see it, I couldn't unsee it. And that motivated me to engage it further. And as I looked further at it, the magnitude of the need became clear, and that has led to a career of a quarter century now working in the medical trauma arena.
Yeah. That's amazing. I agree with you. I feel this so strongly that there are millions of people walking around with medical trauma, and I also think a majority of them do not understand that there is a name for what they're going through. They just think there's something wrong with them.
I think that's exactly right. They don't have a name,
Yeah.
and often, depending on their situation, they don't really have permission. They haven't been given permission to struggle under the weight of what they're experiencing because often the message from well meaning people in their lives, even their healthcare providers, is you've survived the ICU, you've survived cancer, you've survived a cardiac arrest. You should be grateful, right? Like,
Yes.
why are you complaining? Like, what do you have to be depressed about? We didn't think you would make it back. You did. Rarely do people say, sit down and shut up. Nobody says that. But the implication strongly
Yeah.
is please stop complaining, right?
Yes.
Please embrace this gratitude.
Yeah.
And they don't really, they don't know what to do with that. They struggle with that because on the one hand, they're grateful. They're hugely grateful. On the other hand, they feel guilty because they struggle. It's a hard spot to be in the
Yeah.
midst of or on the heels of medical trauma. And we need to give people the vocabulary to
Yes.
describe what's happening to them.
Yeah. Yes. One of the reasons this podcast is here, I'm sure why you wrote the book about
Yeah.
medical trauma. That's like one of my biggest goals is for people to hear the phrase medical trauma and be like, oh, I think that might be what's going on with me. And I will tell you, and I'm guessing that you have the same experience. Whenever I meet somebody and I tell them what I do, they more often than not, they're like, oh, that's why it's so hard for me to go back to the dentist. Or, oh, that's why my mom refuses to go and get the surgery she needs. She's hobbling around, but she won't walk into a hospital. And it's just like this like light bulb moment for them. And that's what I want for everyone
Yeah.
who is walking around and, having nightmares, like all of these really hard experiences that we have after medical trauma that again, like people oftentimes just think something's really wrong with me.
I think that's right.
Mhm.
I think two things are true. There are two things that I notice. One, when I talk about this, somebody asks me what I do. I'm in a lift or on an airplane or in an Uber or whatever. People ask me, and often the idea that medical trauma is common, it resonates usually with them, right? Because they
Mhm.
say, I had a heart attack, or I was in the ICU, or my mom had cancer, or my wife had a miscarriage, or
Yeah.
whatever it might be. So
Mhm.
the the notion that traumatic things are common, they affirm it all the time. They
Yeah.
introduce it often, and I
Yeah.
just get out of the way and listen. Also, as you noted, people do talk about the fact that it leaves a mark, right? It
Yeah.
leaves a mark, and that mark, as you alluded, often is related to things like avoidance, right? Like there
Yeah.
are there are steps I need to take to stay healthy. There are
Yeah.
things I need to do to stay upright. And by the way, I'm not going to do those, right? I don't do those because it's too scary. And
Yeah.
I understand it. Uh, I get it. And it's incredibly unhelpful for them because, as you know, if you have chest pain, the longer you wait to go to the ER, right? Because you're afraid because it's triggering something or other, the more likely you are to have a bigger problem related to that
Yeah.
heart attack than you would have been, right? The
Yeah.
longer you wait to deal with an infection in your tooth, the more likely you are to get sepsis. So
Yeah.
this avoidance is no small thing. It has real world ramifications for people and for their families.
Oh, absolutely. I'm just thinking about, how powerful our nervous systems are,
Right.
right? And they're trying to protect us, and they know that something that was really scary and felt really dangerous and oftentimes life threatening has happened in a
Yeah.
medical setting. And so it makes so much sense that our systems are screaming, do not go in there. That makes sense. Um, and so I'm thinking about in the work that you do, how when you're working with somebody who is like, "No, I'm not going back, I'm not gonna get that treatment," like, what are some things that help them make the shift to be able to step back into a medical setting?
So it's a really important question. It's a really important question. And it's a difficult one. Really, in some ways, the thing that put medical trauma on my radar
Mhm.
in a big way, and I talk about this in my book, is that I had seen a patient one day, and they told me a story. I'll share it here. So they had had an emergency surgery. It had gone well, and they had gone back to the recovery room, and they
Mhm.
had been spiking a fever shortly after the surgery,
Yeah.
spiking a fever.
Yeah.
And it turned out that the surgeon, this was not at Vanderbilt, by the way, but it turned out that the surgeon had had left a towel. Someone had left a
Mm,
towel in this
mm,
person's abdomen. They were
mm,
spiking a fever, and so after this emergency surgery that had gone well, they had to have yet another emergency
mm.
surgery, and
Yeah.
that one didn't go too well, and that was incredibly traumatizing, hugely so for them. So when I saw them, um, they had a bunion on their foot, a minor, I think
Yeah.
most people would think an inconsequential thing, and it was preventing them from walking very far at their job. They had a great job. They
Yeah.
needed to walk at their job. So it could have been solved, the problem solved with just a minor outpatient procedure, a bunionectomy,
Yeah.
and they didn't do it. They were not doing it. They
Mm,
were not doing it. And their calculus was, I actually would rather lose my job, right? I'm very willing to lose my job than do something relatively minor, not minor to them, that is
yeah.
going to save my job. I'm not doing it. Wild horses aren't going to get me to do it. And that's the level of avoidance, I think, that
Yes.
people often engage in.
Yes.
And they engage in that. I can empathize with it. I can be pretty avoidant, but they engage in that at their own peril. Inviting them to lean into that avoidance is no simple thing, but
Mm,
people can learn to do it, right? People can learn to do it, and one of the things I like to do, and this idea borrows from acceptance and commitment therapy, which
mhm.
to me is one of the most helpful methods of engaging people with medical trauma, is really helping people identify what their values are. What are your
Yeah.
values? What are the things that matter to you? And if we can identify what those values are, we can use those as a lever to propel people into doing hard things that they don't want to do.
Mhm.
Um, so, part of it is not going to the doctor to remove the bunion. It's not just impacting you, right? It may impact your wife. It may impact your kids because now your wife might have to return to the workforce because now you can't do your job. Now you've been fired from your job, right? So
Mhm.
often patients are not motivated by their own concerns, but they might be motivated by values which are, I love my wife, right?
Mm,
I love my kids. I don't want to be in a situation where we can't pay the mortgage because that's going
yeah.
to affect these three little ones, right? So when people can lean into their values and embrace them, those can propel them to do hard things they don't want to do.
Yeah.
Um, Avoidance is a huge problem. It's a huge problem in the lives of people with medical trauma. And I think what happens is, I know this from my own life, the more you give into anxiety, the more it sets up shop in your life, right? The more
Yes.
territory it takes. And before you know it, it's taken up all the territory you have, right? And
Yes.
and your life and your vitality has really shrunken and diminished. So reminding people you're braver than you know, right? The fact that you're on the other side of this, that you've survived it, it says a lot about how resilient you are. How can we use that perspective? You're stronger than you know as a tool to get you to lean into hard things. I think that's the key.
Yeah, I have a million thoughts that are coming up. First of all, I have to say, I also know the feeling of anxiety being like, don't do it, Sarah. Don't do it. And it's funny because of my experience, I am trying to help my kids learn for themselves as they're young, like, hey, you give anxiety and avoidance an inch, it's gonna take a mile.
Right.
And I one of my kids wanted to avoid something that was scary, and I'm like, if we leave, coming back is going to be much harder than it was to
Yeah.
come here today. And so trying to teach that, and that's logic, right? But one of the things that I like to do is help people understand what's happening in their nervous system,
Yes. Right.
because I feel like that can take away some of the power,
Right.
because our nervous system is saying, like, no, you will die if you walk back in there. You will die if you
Exactly.
go and get that bunion removed. Something horrible is going to happen, and this time you're not going to survive it.
Exactly.
And so to like get an understanding of what's happening in the nervous system, and that their nervous system is responding as nervous systems do. There's nothing wrong with you for your nervous system responding that way. But to just kind of learn about the different responses that
Right.
happen, the different ways that they might feel, I think just take some of the charge off of that big, you know, feeling of I cannot do it. If I do it, I'll die."
Yeah, I think that's right. This cannot be a purely cognitive exercise, right? Like that
Right.
hasn't gotten anyone anywhere, right?
Yeah.
Almost never does, right? Can't be a purely cognitive exercise. The other thing I would say is it's really important to highlight for people that just because you're quite anxious about something doesn't mean that you can't do it, right? Like
Right.
you can coexist with anxiety. And I
Yes.
talk to patients about this a lot, about the idea that we can learn to treat anxiety as an unwanted house guest. That's the term that I use, not original with me, but like an unwanted house guest, meaning, gosh, your difficult great uncle, he's moved into the apartment over the garage. It's not your favorite thing that he's there, and you can adapt, right? It's
Yeah.
okay. And often I think we wrongly communicate to people that you can only reach goal A and B and C and D. You can only make progress if we eliminate all of your anxiety, right?
Yes.
And the truth
Yes.
is, you know what? That anxiety may be a pretty permanent companion of
Mhm.
yours. And if it is, that's okay, right? Like you can still live a really rich life with anxiety. I
Yeah.
wish you didn't have it. We're going to help treat it, but
Yeah.
let's move away from the fact that I can't do this, I can't pursue that unless we remove all the anxiety. No, no, no. Like the anxiety can be there and you can still do it.
Yes, that makes me think so much about, I think of it as the phrase capacity. People talk about window of tolerance,
Yeah.
but I feel like, yes, sometimes, especially when people are early on in this process, they
Right.
want to not feel it anymore. And it's like, actually, what happens as you recover or as you heal, whatever word you want to use,
Yeah.
actually, you get this bigger capacity to be with the uncomfortable
Right.
sensations.
Yes.
And
Yeah.
know that you can keep going. Oh, yeah, I can feel my heart pounding, and also, I'm choosing to
Yeah.
go to this appointment today.
It's so important. When we started our work with long COVID patients early in the
Mhm.
pandemic, we started support groups, and I counted them at one point. We had led, I think, 550 of them. So we'd led a
Wow.
lot of them, and it was a point of real pride of ours. We really, I think, helped a lot of people in the context of this support group program. Probably no more than they helped me. I mean, they taught me so much.
Mhm.
And one of the things that we heard from a lot of our long COVID patients was this idea that I'm only going to be okay if my long COVID doesn't go away. I'm never going to be okay. And I understand why people feel that way very much.
Yeah.
And I think it's a very unhelpful framing, right?
Yeah.
Because we can insert medical trauma here, right? Your
Right.
long COVID might never go away, right? Your medical trauma might never go away. And if you're waiting to live a full life until your long COVID goes away,
Yeah.
sadly, you might be waiting a really long time. So I think
Mm.
our message to people is very empowering when it includes that insight. I think it's less helpful when we communicate, even inadvertently, you know what, we're going to find a magic wand. We're going to find a 5-star treatment. It's going to take all your depression away. Well,
Mhm.
maybe, probably not, and this is very personal to me. In 2018, I was diagnosed with OCD.
Mhm.
And my OCD was quite a challenge.
Mm.
I didn't ask for it. I definitely didn't want it. And I went to see a psychologist. She's amazing. And I said in so many words, like, "Hey, how do we get rid of this anyway? Like, I really don't like this. Like, this is
Yeah.
causing me a lot of problems. How do we get rid of it?" And she said, Jim, I don't really think we're getting rid of it. And that was a painful awareness, hugely emotional awareness for me that we're not just getting rid of it. Her suggestion was you can learn to live with it. And she was compassionate, of course, in saying that, but I had no interest in that. I mean, candidly, I thought other people can learn to live with that. I'm not, like I
Yeah.
eat problems for breakfast. I'm not learning to live with it. And I made exactly no progress for probably a year and a half or so.
Yeah.
And one day, I mean, I saw her faithfully. And one day, it was almost like I had an epiphany. I thought, maybe I can explore the possibility that I could live with this, that I
Yeah.
could accept it. And when I did, everything changed. The whole dynamic started to change. And I think sometimes in mental health, even though we're very good at what we do, we suggest to people that the treatment process is going to be a little more complete than it might be, that it's going
Yeah.
to be a little easier than it might be, that it might be faster. And I think sometimes that's fool's gold.
Yeah.
Sometimes this change is really hard.
Yes.
Sometimes it's frustratingly incomplete. And so, I'm very motivated to help people change, but I think a more powerful message is even if we don't get you back to that place where you were,
Yeah.
before your cancer, before your trauma, before your cardiac arrest, whatever it might be, we can find a way for you to be okay. Trust
Yeah.
me, we can find a way for you to be okay, even if these symptoms don't go away.
Yeah. I love that. I'm writing that down. We can find a way for you to be okay. I think that's really beautiful. Yes, well, I think one of the things too, as you were talking, is I was really relating to what you were saying for me personally as well. So, within medical trauma support, I show up as a peer and
Right.
I also share nervous system education. And what you were saying about your own journey with OCD reminded me a lot of my trauma healing journey
Yeah.
and just I think early on I did think that I was not gonna feel anything, but what I found is actually the opposite
Right.
was you're gonna feel things,
Yeah.
but I built this capacity to be with it. I built this, ability to recognize it as anxiety and
Right.
a nervous system response versus, "This is gonna kill me, and I
Right.
can't do it," right? Because
Exactly.
that's what anxiety tells us. It's like, "No, dude, this will kill you. This is you cannot do this."
It does tell us that, as you noted, as we discussed, when you give it an inch, it takes a mile. And,
Yeah.
and I think the other thing I would say, just taking a half step back related to my OCD, I think with the emergence of mental illness or mental health problems, whether it's in my case OCD or whether it might be bipolar disorder, depression, anxiety, I think often we don't frame those things as traumatic, and I think probably we should. And what I mean by that is, with my OCD at least, the OCD caused its own problems, right? There were obsessive thoughts, and there was difficulty with uncertainty, and there were these profound fears, and those were what they were. But there was a little bit of a double whammy, which was, hey, I'm dealing with these on the one hand, and I'm dealing with the fact that this brand new problem that I didn't have before has just hit me like a freight train,
Yeah.
and that feels really traumatic. So I think there
Yeah.
were two things going on. One, dealing with the trauma of a mental illness that you didn't have and don't want, and
Yeah.
two, dealing with the practical challenges of that disorder.
Yeah.
And I think probably we don't affirm quite enough that in the mental health arena, even a diagnosis of a mental health condition can be a trauma in its own right.
Agreed. Yeah, agreed. And the word that kinda came out for me is, like, shocking,
Right,
right? That feeling of, like, "What is happening? Like,
right,
what
exactly.
what is this?" And that's true for mental health, it's true for all of it, right? You know, a cancer diagnosis, like different things that happen that we're really not expecting, which that is such that piece, that like shock, that unexpected shock is such a piece of a traumatic experience.
Yeah, I mean, in my own, I agree with that, Sarah, and in my own way of thinking about it, that shock piece, that's in some ways the most singular, right? That's one of the
Yeah.
very most problematic parts to me, which is I was just whistling a tune. I mean, we hear this from patients, right?
Yeah.
Which would be I was in very fine health, right? Or this was a routine surgery, or um, my baby's heartbeat was fine and until it wasn't, or whatever the case. But so often it is things were going quite well for me, and then I was literally blindsided, right? And I was left, as it were, by the side of the road, not having any idea how to pick myself up, not being given any language to describe this, and often being told, again, depending on the situation, hey, you can get pregnant again. You're young, no big deal, right? Or it's
Right.
just anxiety, or some people didn't survive. You should be really glad, or whatever. And I think that dynamic of being dismissed. I mean, we can call it gaslighting, we can call it whatever we want, but that dynamic of being repeatedly dismissed over time by people who should know better, by people who you should be able to trust, who you thought you could
Mhm.
trust. That also is a problem, right? So we have to fold
Yeah.
that in to this experience of medical trauma too.
Yeah. One of the things that I often think about and I've talked about in our peer groups is when let's say we're at the grocery store and like
Yeah,
our groceries are being bagged and the person that's bagging the groceries is kind of a jerk, right? Is
yeah,
like really disconnected and short with us. That happens. And we can be like, "Oh, what a jerk," and
yeah,
kind of move on with
yeah,
our lives. But when we are in a medical setting,
yeah,
sometimes in the scariest time of our lives, and somebody treats us like that, it it hurts so deeply because we're so vulnerable, but also because we expect that when we step into healthcare that it's a healing place and we expect it to be this holistically healing place.
yeah,
And then oftentimes we run into maybe somebody who is just so burnt out because they aren't getting what they need. Their needs
right,
aren't being met by the
yeah,
system that they're in.
right,
So maybe they're burnt out. They make an offhanded comment, but it means so much to us because we're there to be helped.
yeah. I think it's particularly painful when that happens. And I think the other thing about this that is really hard is we teach patients, you teach them, I certainly teach them to be assertive, to set boundaries, to not tolerate behavior that doesn't feel okay. And the thing that is difficult for many of them is, wow, this person that is engaging me in a way that doesn't feel okay,
Yeah.
this is the nurse that I'm going to see at my dialysis session every single week, right?
Yeah.
Or like, this is the only oncologist in this entire rural county where I live, and I'm really afraid of making them mad, right? Or whatever the case might be. So people are really in a dilemma. This came up in our support group just yesterday in a little
Yeah.
different context, which is someone was talking about family members who were being unhelpful and difficult and perhaps even
Yeah.
hurtful in the way that they were engaging them. And one of the members of the group said, you can remove difficult people from your life. You can do that. And other members of the group said, yeah, you can, but these might be the same people that you're relying on to take you to the doctors,
Yeah.
right? And to care
Yeah.
for you in some very fundamental ways. I think some of our patients feel like they're really caught betwixt and between, right? Like on the
Right.
one hand, these insults broadly defined really sting. On
Right.
the other hand, they want to set crisp boundaries and say that it's not okay. On the other hand, they're worried that if they do that, it's going to have some consequences for
Yeah.
them. So
Yeah.
trying to figure out how to be wise about navigating that,
Yeah.
it's really complicated.
It's really, really complicated. It's really complicated. as a social worker, I think about systems a lot too.
Right,
And I think about how challenging it is to change systems.
right.
And we can see being in this and talking to so many people about their experiences that
Yeah,
things really need to change in the medical system.
right.
And what can we do in this moment? Like, what can we do as advocates? What can we do as the patients?
I want to comment on one thing that you said that I think
Mhm,
was really helpful. One thing you did. You pointedly used the word and just a minute ago. You emphasized the word and that was beautiful because I think people who cope better with medical trauma, and I
mhm,
talk about this in the book, people who do better with medical trauma, that they embrace the both andness, if you
mhm.
will, of things, right?
Yeah,
I find that they learn to use the word and in the context of the things we're talking about might be this person was really abrupt with me and I know they still really care about me, right?
yeah,
Or, um, this family member is really frustrated at me and I don't need to cut them out of my life completely, right? So
yeah.
embracing both and as opposed to either or, I think is so important. And I appreciate you doing that even in this interview. It's really good. It's really good modeling for your listeners.
Oh, well, thank you. The word that came up when you were talking about that, and I had thought this word earlier when you were talking about something else, is the word nuance,
Right.
right?
Yeah.
There are a lot of people who have a hard time with nuance
Yes.
and that multiple things can be true at once.
Right. Yeah.
And I think that applies so deeply to medical trauma, the whole medical trauma experience.
Yeah,
And
it does. It does. And I'm very
mm,
cognizant as somebody who leads groups and, interacts with a lot of patients. What I need to do, what you need to do is much more than modeling. We need to do much more than modeling, but I'm mindful of the fact that I'm modeling um, what I hope my patients will demonstrate. And I'm really conscientious about trying to use and, right, instead
yeah,
of but, just a simple thing. And I'm aware of trying to think that way. And I think that's one of the key themes in the book. This book is a self-help guide, and I think it's a very hopeful one. Now, you won't find unicorns and rainbows
mhm,
on the pages of Reclaiming Your Life from Medical Trauma, but I think it's actually really very hopeful. And
yeah,
and one of the messages in the book, perhaps the key message, is that medical trauma is really difficult and you can find a way forward
yes,
even if your medical trauma is really difficult and you can find a way forward even if you're grappling with it.
yeah,
I think that is the key theme because I think that's what we need to say to patients. We need to say to them with such compassion, you have experienced shockingly hard things,
yes,
perhaps, absurdly, insanely hard things.
yeah,
And even with that, we can find a way for you um, to engage in a really rich life. Now, that
yeah,
doesn't happen. The book highlights the fact that that doesn't happen by accident, right? That usually
mhm,
doesn't happen by accident. And that often happens in the context of really specific things that the book, I think, very helpfully talks about. It happens in the context of finding social support, right? Like
yes,
finding
yes,
your people, right?
yes,
And I have found, and perhaps you'd agree, that in general, in general, people do better after medical trauma when they have other people around them.
yes,
People do worse if they try to go it alone, right? So that's a practical insight. There are many others. One other one would be um, there's a rhythm of life that you can learn to live. It won't fix everything, but that rhythm of life that prioritizes getting sleep, right? That
yes,
prioritizes knowing your limits, that
mhm,
prioritizes engaging with other people, that prioritizes trying to find meaning in things.
yeah,
That rhythm of life, that's going to help you, right? Combined with social support, that's going to help you. The book talks about approaches to treatment that are more and less helpful.
Mhm.
As you know, all treatment is not created equal, right?
Mhm.
And I cringe at times when someone says, "Yeah, I went to see a therapist. It wasn't really very helpful." And you say, "Well, what did you talk about?" And they say, "Oh, we talked about the weather a lot. We talked about my baseball card collection, whatever it was, right? Like all therapy is not created equal." And the book offers what I think is a scientifically grounded vision of the most effective approaches we know of to
Uh-huh.
treat medical trauma. And there isn't just one, there isn't just two, but there are things that are more and less effective. When when I sent the book out to this is the way it works, by the way. You send the book out to a gazillion people to endorse it. And then if you're lucky, a few people send endorsements back, right? You get a lot of messages that say, "Hey, I'm really famous and I'm really busy and, I can't endorse your book. I wish I could." You don't take them
Mhm.
personally. But one of the things that people consistently said about this book that really made me happy was it was very practical. It was really practical.
Mhm.
And I think, you remember Maslow's hierarchy of
Mhm.
needs from Psychology 101 or whatever. And I think the point of Maslow's hierarchy is, when you're drinking out of a fire hose, trying to battle this overwhelming stress, trying to manage these challenges that are existential.
Yeah.
Um, you don't have time and you don't have the wherewithal necessarily to read complicated academic literature reviews, right? And to do deep dives into the latest and the greatest. You don't have time to do that. So the book is really meant to be a distillation of clinical insights that are proven, scientific insights that are robust, the things that I've learned about my own struggle with a chronic illness that I would
Mhm.
call a form of a trauma. And the take home is, this isn't easy, it's not quick, but what of any significance is, right? Like Robert Frost, the poet, my favorite poet, he had a famous quote: "The only way around is through," right?
Yeah.
And on my desk here, I'll hold this up. Your listeners can't see it, but this is called Dr. Pierce's Compound. I'm holding up a little bottle from maybe 1910 or so.
Mhm.
This is an elixir from Dr. Pierce, famous turn of the century doctor and flim flam man who, manufactured these bottles of alcohol, I suppose is what they were. And they were supposed to be a cure for everything. And Dr. Pierce, it's a distant relative of mine, I learned.
Mhm.
My aunt used to talk about it. And so I keep this on my desk, this elixir, to remind me, there's really no elixir, right? Like there's no
Yeah.
elixir. As
Yeah.
Robert Frost said, the only way around is through. And that doesn't mean that there aren't reasons to be hopeful. There are so many reasons to be hopeful, right?
Yeah.
Post-traumatic growth is
Yeah.
something that I witness in my patients and
Mhm.
you probably do in yours. And when you see it, sometimes through tears, it's
Yeah.
beautiful to behold.
Yes.
But um, there aren't shortcuts, right? It takes
No.
time. And the book is meant to be a safe and reliable guide, a tender and compassionate guide that will help people find a way to thrive on the heels of medical trauma and not just to survive.
Oh, I love that so much. Post-traumatic growth, I see that. I do see that a lot. And, I shared that I have a peer community. And what I find is a lot of times what comes up for people who are starting to experience that post-traumatic growth is they are ready to be of service to others, right?
Right. Yeah.
They remember, and it's probably partly why we're also doing this work,
Right.
right?
Yes. Yeah.
We know what it's like to be
Right.
in the dark places,
Yes.
and we figured out how to climb up the ladder and, and start to find light. And I just feel like that seems to be such an indication of post-traumatic growth is someone saying, I know how hard that was. What can I do to help others who are where I was?
Yeah. Yeah. I agree
Yeah.
with that. And the support group we had just yesterday, we have a medical trauma support group every other week. And it was just so tender. It was so deeply moving to see this situation, kind of a crisis unfold. and everybody virtually, just surround the person that was
Yeah.
struggling, and
Mhm.
do it from a place of such kindness and such
Yeah.
goodness. It wasn't transactional. It wasn't, I'll do this for you, and then the next time I'm struggling, you'd better do this for me. It wasn't
Right.
that. Our society traffics in that a little too much these days.
Yeah.
It was just pure kindness, and I see that in our patients, and I think not all of them, but many of them have struggled so much, and they're in this beautifully reflective they're in this beautifully reflective place,
Mm.
and many of them feel like they have been given a new opportunity,
Yeah.
perhaps, and that doesn't mean they're grateful all the time, right, for what they've been given. From that, organically flows a desire to help other people, right?
Yes. Yeah.
So, I love post-traumatic growth. I learned some time ago, you can't try to force feed it to people, right? Like,
Yeah.
that's very cruel, but you can get out of the way and watch it unfold. When that happens, right, it's really a lovely thing,
Mhm.
and it's beautiful to see.
Yeah, and I wanna go back to what you talked about with your book, and that was hope, that it's
Yeah,
hopeful, like, it's not artificial,
right.
it acknowledges what is true and authentic and real,
Yes,
and again, to use the nuance, right, of and there is so much hope, and I think, again, to go back to you and I both sharing some of our lived experience and experience of being with other people and seeing that we have seen it, we have
right.
felt it, we
Yes.
know after you've been in the dark,
Yeah,
when you've been in the absolute darkness and you have found light and you've been able to move toward that, it's that's I think where the hope really comes from because we actually know deeply in our bones that we can feel better and that hope piece I think is why I'm here, why I'm doing this
yeah,
and I've talked to people who are like, how can you like just hear like horrible things that people
yeah,
have gone through all day?
yeah,
And I'm like, because I know so deeply in literally in my
yeah.
bones that we can heal or recover, whatever word people want to use, right? We can move out of the darkness.
Yeah, I think it's so true, and when I think about my OCD, it's funny, in the first book, you won't find this in the first book because it got cut from the first book,
Mm,
but I wrote about my OCD a fair bit in the first book, and my editor, who was so amazing, said, "I think you need to back off a little bit. That's a little too dark." And I remember thinking, well, if you think that's dark, right? Like you should be aware of all the things I did put in the book because that wasn't very dark to me. So like you,
yeah,
um, I've been in really dark places, and I
yeah,
think patients, psychologists or therapists, they can decide. It's up to them. They can decide how much to disclose or how much they want to keep their own stories close to the vest. There are reasons why they might do one thing or the other. For me, um, while I'm mindful of boundaries and I think
mhm,
appropriate, I'm pretty willing to tell my own story in the
yeah,
context of the support groups that I lead,
mhm,
and I think it's powerful. I think patients often can relate to you in a different way when
yeah,
when they feel like I'm not the only one who's broken, right? Like this
yeah,
therapist that is engaging me, he's walked down this broken road too, right?
yeah,
And he or she has been there, and I'm going to put maybe a little more trust in the validity of what they're inviting me to do
yes,
because, you know, they also are a little bit broken. And I think that's really important. And I think, when someone has been in a really dark place and they have found a way to come out of it, out of the other side, and maybe they move back into it. Maybe it flares up, but they don't live there. I think that's a testimony to the rich life people can have,
yeah,
even in the midst of painful things. For a long time, I wanted to put my OCD behind me. I wanted to lock it up, right?
mm,
Wanted to put it in the closet, nail the door shut. I prayed that it would never come back. Sometimes it does, right? Sometimes it
yeah,
does. And when it does, that's okay, because I have realized that I can live with it, right? If it comes
Yeah.
back up, I'll deal with it. And and I think I just say this to say with our medical trauma patients, sometimes the trauma flares back up, right? Like sometimes it flares back up. And
Yeah.
often the tendency for our patients is to think, oh my gosh, it's back, right? Just like the
And I'm back
Terminator,
to the beginning, and
right?
I think oftentimes people will think, "It's back, I'm back to the beginning. Great.
Exactly.
Work I
Right.
did was for nothing."
Here we go again, right? I'm
Right.
back to the beginning. And to remind them, you know what? There are other ways to think about that. There are other ways to feel about that, right? Let's make space for it. I think
Yeah.
it's important, right? Like somebody gave me the analogy, and I share it with patients a lot. I really like it. Like we used to have a pool at our old house. I'm so happy, by the way, that we don't. My wife and I would fight a lot about who would clean the leaves up. We had all these trees, so I kind of hated that pool, to tell you the
Mhm.
truth. But you know, you could imagine this analogy where you've got a beach ball in a pool
Mhm.
and it's floating over by you, and you grab it and you try to push it underwater,
Mm.
and it pops up in your face and you get all wet. Versus you notice it, you don't attend to it, and before you know it, it's floating around in the deep end. It's not even bothering you, right? And I
Yeah.
think this is the approach that we would be wise to use if we could
Mhm.
with some of our symptoms that are distressing. Let's not grab them and try to push them down, because the more we do that, the more they're going to pop up. Let's
Yeah.
find a way to notice them, not to be too attached to them, because if we do that, usually what happens is a day or two later, they're floating at the deep end of the pool and we've
Yeah.
gotten a reprieve.
Yeah. If we had a few hours, I would wanna talk about the neuroscience of that because I
Yeah,
think it's interesting. Something that is coming up so strongly for me as we're talking too is, I think, an experience that probably all of us have with trauma, medical trauma, is shame.
yeah, yeah. It's such a concern, right? Like guilt is a problem, but shame is a whole
Yeah.
different deal, right? Like
Yeah.
it's much more subterranean. I see it in my patients all the time,
Yeah.
and very often what happens is they not only have the shame, but then they have guilt because they have the shame, right? And it becomes a huge big problem. And I think there's no one way to target the shame necessarily. I mean, shining a light on it, I think, whatever that looks like, is important.
Mhm.
But helping people remind themselves, helping people embrace the idea that there are things in their life that they can't control, right? Like their
Mhm.
biological realities that
Yes.
are out of their control, that they're not to blame for, that they can't influence. I think that's really important, right? For me, I had such profound shame related to my OCD.
Yeah.
And the early message I got, which was, hey, this is a biological problem, right? Like this is a
Mhm.
biological condition, Jim. Didn't impact me much, right? Because I think in my case, my own narcissism told me I don't care if it's hardwired, right? Like I should be able to, I should be able to cope with it. And dealing with shame takes some time, I think, but often in my mind, it's dealt with effectively through gently inviting people to consider the possibility that maybe they're not really to blame for this
Yeah.
outcome, right? The surgery that didn't go well,
Yeah.
not their fault. The fact that they got sepsis, not their fault. The fact that they had breast cancer or melanoma, whatever, not their fault. I always start by inviting people to consider that, right? Like that's the place to start. Telling them is completely ineffective. I think it's not appropriate. To me, it's a little like the stages of change theory, if you're aware of that. Stages of change
Mhm.
theory posits that we change in the context of multiple stages. The first stage is thinking about thinking, pre-contemplation.
Mhm.
So, you know, I'm not ready to think about stopping smoking, but I'm thinking about the fact that one day I need to think about it. That's
Mhm.
pre-contemplation. Contemplation, I'm now thinking about it. I'm not ready to act on it. I'm thinking about it. The next stage, action, now I'm ready to change it. So
Mm.
similarly, what I see with people is I'm not really ready to accept that this isn't my fault
Yeah.
because, there's some amount of control that I gain by the suggestion that it is my fault. So
Right.
not ready to think about the fact that it's not my fault. I'm certainly not willing to accept that it's not. But maybe I'm ready to think that one day I could maybe believe that it's not my fault, right? And if you can get somebody started flexibly, often they move through that place to get to a healthier place, I think, where they can say, you know what, living in uncertainty is scary.
Yeah.
Acknowledging that I don't have control over every outcome in my life is scary. But here we are. Here we
Yeah.
are.
Yeah. It makes me think a lot about, your book on long COVID, like,
Right.
especially when, um, you don't necessarily have a name or a diagnosis for something. So, like, rare disease, long COVID, especially before people were acknowledging that it was real,
Right.
right?
Yeah. Yeah.
I actually just had someone that I just will be releasing a podcast for somebody who had a COVID vaccine injury.
Yeah. Right.
Talk about going and trying to find treatment and people believing it's not real and the shame you feel. I feel like shame is just such, a common
So
thing that's
common. It's
inbuilt with
so
us.
it's so common, and I think you mentioned systems. I think you said earlier, I'm a social
Yeah,
worker and I value systems or some such thing. And I
yeah,
think it's worth noting, I think it's worth remembering that although we've come a long way as a culture related to mental health
mhm,
or physical illness, if you will,
yeah,
um, we still as a culture conflate health problems with weakness, right? And we
yeah,
conflate mental illness with being bad or inadequate or whatever it is.
yeah,
And it's better, but we have a long way to go, right? And I think,
yes,
for me, um, when I'm on podcasts and in the run up to the book being released, I seems like I'm going to be on a lot of them, and I'm grateful.
mhm,
But I really try hard, and it comes from an authentic place. I'm not having to force myself, but I really try hard to be honest about my own struggles because the hope in that is, if I'm taking my mask off here, maybe somebody else will feel a little less ashamed when they
yeah,
do it, right?
yeah,
And
yeah,
I think the onus is on us as healthcare professionals, um, to be brave and willing to be authentic, right? And
yes,
in doing that, um, I think maybe we give permission for other people to do the same. And in that process of being vulnerable, seems to me, um, people over time become a little less ashamed.
yeah,
But the more we hide things, right? The more we um, describe things as sort of outside the boundaries of what we can talk about,
mm,
the more we see things in strict black and white categories, to
yeah.
me, the more shame is likely to thrive.
100%. I think it's one of the reasons that I love peer support so
Yes.
much.
Right.
So much in my peer training, one of the main pillars or core values of
Yes.
peer support is
Yeah.
authenticity.
Right.
And
Yeah.
I thought, I am in the right place.
Yeah. Me too.
This,
Too. Yeah.
this is this is my place. Well, I usually end these podcast episodes by asking my guest if there is one thing they really want to make sure that the
Mm.
listeners leave with.
Yeah.
And I would love to offer you that. And I also feel like what you just said was a huge thing to leave listeners with.
Yeah.
But
Yeah.
is there something else that you feel like if somebody listening could walk away with this one little nugget,
Yeah.
what would it be?
Yeah. Well, I love it that you're giving me that opportunity, and thank you. We're kindred spirit. I don't know you, Sarah, but I feel like I do now, actually.
Yeah.
And I think we're kindred spirits. I think the message that I would communicate to people, I alluded to it again, but it's worth highlighting. That is, um, you can find a way to live a meaningful life
Mhm.
in the midst of medical trauma, even if things aren't okay, right?
Yeah.
Like, even if the trauma doesn't go away as much as you'd like,
Yeah.
even if you're not completely cured of the cancer, even if you have another miscarriage, whatever it might be, you can find a way with help and support to
Mhm.
be okay. You can find a way to live a rich life, even if the medical trauma doesn't go away.
Yeah. That's beautiful. Thank you.
Yeah.
And you've talked about your book. I'm wondering if you can say what the full title is again, and other ways that maybe somebody who's listening and what is interested in one of the support groups that you're running.
Sure.
If you could share some of that, and I'll also put links to them in the show notes so people can access it that way as
Yeah,
well.
thank you. So the book is called Reclaiming Your Life from Medical Trauma.
Hmm.
That's the first part of the title, but it's the only thing that people need to know. Reclaiming Your Life from Medical Trauma. It's available on Amazon. It's at Barnes and Nobles. It's at every place I think that sells a book. There's an audio version. It's funny. I had badly wanted someone to read it who had a British accent. That was really my goal because to me, the Brits sound kind of very official and authoritative.
Hmm.
And my agent said, you're not very British, Jim. So I don't think we should have a British narrator. So I don't, but there's an audio version available. Um, I'm at Vanderbilt. I'm one of the leaders of something called the Critical Illness, Brain Dysfunction and Survivorship Center, and I'm the director of behavioral health at a place called the ICU Recovery Center at Vanderbilt.
Hmm.
If your listeners have had a significant illness and they're interested in a clinical consultation, they could find us. They could find me at Vanderbilt. They could make an appointment at the ICU Recovery Center. We'd be happy to support them. We have support groups, as it sounds like you do. We have many of them. Um, if someone if someone is listening and they'd like to start one, uh, if I can serve them by teaching them how to do that, it's really my pleasure. I think individual therapy is hugely helpful. And I think I can comfortably say that the places where I have seen the most profound change have not necessarily been in the context of a one-to-one therapy exchange, but often they've been in the context of people taking their masks off together, deeply loving one another, reminding each other of what is possible and supporting each other along the way. So, if you're listening and you're not in a support group, let us help you find one
Yes.
because, I think in many ways, that is one of the most vital things you can do on your pathway to thriving, uh, hopefully not just surviving.
Yes, I agree with you. It's like there's something magic, and I'm sure there's science behind it, but there's also a little bit of magic.
Feels like magic to me.
Yes, it's so beautiful. Well, thank you so much, Jem, for sharing your time and your wisdom, and this was wonderful.
You're so welcome. It's really my pleasure and look forward to connecting with you next time I'm in Austin.
Yeah, for sure. Thank you so much for being here and for caring about bringing more humanity into healthcare. And if this conversation meant something to you, please share it so more people know they're not alone in their medical experiences. You can find resources, education, and our peer support community at medicaltraumasupport.com. And if you enjoyed this episode, please follow, subscribe, and leave a review. It really helps more people find this podcast. Take care of yourself, and I'll see you next time.